So this is a 35-year-old man that's got a 48-hour history of pain, stiffness in the small joints of his hand and feet. He's got previous episodes over the last year. He's saying that the stiffness is worse in the early morning and after periods of inactivity, and is gradually relieved by gentle exercise. His last medical history was notable for hyperthyroidism, and we've got increased ESR, CRP level, and positive rheumatoid factor. So which is the following extra-articulate manifestation of this condition? Amyloidosis, pulmonary fibrosis, subcut nodules, episcleritis, vasculitis. Have a think, guys. Which one is the most common extra-articular, so outside the joint manifestation for this particular diagnosis? And the question is, what is the diagnosis? Give you 5 more seconds to have a think. Now, if you have chosen option C, subcut nodules, well done. Give a clap for yourself. Now, this is a 35-year-old man. He's got the following key features that jumps out at me. Symmetrical pain, stiffness in the small joints of the hand and feet, morning stiffness that improves with exercise, recurrent episode over the last year, elevated systemic inflammation markers, ESR, CRP, and positive rheumatoid factor. Now, this points to me that this is probably rheumatoid arthritis, which is going to be a chronic systemic autoimmune disorder that's normally characterized by a symmetrical polyarthropathy. So it affects the small joints and also the medium joints in the hand and feet. Okay, so the pain and the stiffness in the joints is classical presentation here. And morning stiffness is going to be very important here, which improves with activity. Remember, this is different to osteoarthritis, wear and tear, where you're going to get worsening pain towards the end of the day. With osteoarthritis, wear and tear, the more you use it, the worse the pain it gets. Whereas this exercise is helpful. Okay, so what about in terms of the actual answer options that you have here? Amyloidosis. Now, amyloidosis is a very rare, severe complication of very poorly controlled rheumatoid arthritis. And it occurs due to amyloid deposition in the various organs, but this is not the most common extra-articular manifestation of rheumatoid arthritis, and neither is pulmonary fibrosis, okay? Because that's much more common with interstitial lung diseases. Subcutaneous nodule is the correct answer because that occurs in about a quarter to about a third of all rheumatoid arthritis patients if they're not managed properly. So often these are the elderly patients who don't have the access to the acute and early referral that we have now. And these nodules are firm, they're non-tender, they're mobile, and they can be found on the extensor surface of the forearms, the elbows, the fingers, and also on the Achilles tendon and the sacrum. Okay, and these are often in patients who have severe active disease or seropositive, so they've got positive rheumatoid factor, they've got positive anti-CCP antibodies as well. Obviously, these can cause mechanical discomfort because due to pressure or due to friction, but they themselves are asymptomatic. Now, you do get some elements of ocular manifestation of rheumatoid arthritis. By that, I mean things like episcleritis and scleritis, okay? But they're much, much less common than subcutaneous nodule. And episcleritis, to give you a bit of a reminder, is just a benign self-limiting condition that's characterized by episodic inflammation of the episcleral tissue, okay? And obviously scleritis, though, is another very rare complication, is much more severe because it can lead to visual loss if it's not promptly treated. What about vasculitis? Well, rheumatoid vasculitis is a very rare complication of medium-sized blood vessels, but much, much less common than subcutaneous nodules in terms of the manifestation of that particular condition. So bear that in mind. One of the main key clinical features for someone with rheumatoid arthritis, bear in mind, is things like synovitis, okay? So by that, I mean you've got pain, swelling in the joint itself, and the pain is going to be worse at rest, and is going to be, or during periods when you're not actually moving at all. And the swelling is not, is around the joint, but not of the bone itself. That's why you get this boggy feeling. This is all tissue there as well. Okay, so any joint can be affected, but most commonly is symmetrical. Look at the pictures, it's symmetrical of the small joints, small hands, small feet, okay? And you get stiffness in the morning. And you would want to do blood tests. We discussed about the inflammatory markers and the more specific markers. Anti-CCP is a better, more specific that rheumatoid factor. And you need to refer. The reason why you need to refer is the fact that you want to have not longer than 3 months before the onset of symptoms and the start of treatment, okay? Because you want to start treatment like DMARDs, which is disease-modifying drugs, as early as possible, because it reduces disease remission and improves functional outcomes and prevents disability. So just look at the pictures on the right-hand side, right? These are patients with severe rheumatoid arthritis. You can see in picture A, there's lots of polyarticular, so lots of multiple joints, polyarticular swelling of the proximal interphalangeal joints with a wrist deformity as well. And B, you can see the subluxation of the wrist, and you can see the ulnar deviation, okay, at the metacarpal phalangeal joint. So the hands are pointed towards the ulnar, and you can also see the boutonniere deformity of the thumb. Look at that shape; it looks like a banana, so it's deformed like a banana. That's boutonniere deformity. And take a look at the first finger there. It looks like a swan neck, doesn't it? At the proximal interphalangeal joints there, PIPs. So where it looks really at the distal interphalangeal joints rather. There's a fixed deformity there, and you can see again in picture C the ulnar deformity there and massive MCP swelling there.